All right, so SATs and SBTs, right? So both SAT, B for both, right? So we're doing our SAT here, right? And we're doing our SBT. And you have to do an SAT before you do an SBT. You have to do the SAT if you're on sedation, because it's called a spontaneous awakening trial. That means you're taking the sedation off. If they're not on sedation, they pass the SAT, right? And now you're on SBT, as long as they're on the ventilator, right? So SAT and SBT. So it's two different elements. It's RN driven. So the RN is in charge of both of these, right? So the RN does the SAT and the RN does the SBT, or is in charge of. We share this responsibility with the RT as well, right? The RT has no say in the SAT, and they're going to say, get your hands off my SBT. But it's still our job to know what the SBT is all about and how it works. And sometimes if you gain a lot of trust with your RT, you can say, hey, can I put them on pressure support? It's like after you're like a 2-year, 3-year nurse. They'll say, oh yeah, sure, I'm busy intubating over here. That'd be great, right? But what's the goal of SAT SBT is ICU liberation. How do you get someone out of the ICU? You extubate them, right? So extubation is our goal. So really you can think of SAT SBT or this B letter as 3 components: the SAT, the SBT, and then the extubation, right? Because who's in charge of extubation? That's the MD or the provider, right? So the provider or the MD are the ones that decide on extubation. The RN and the RT are all doing all these things behind the scenes, and then when rounds happen, it can be a perfect conglomeration where, hey, they're passing, can we take them off? Sure, let's take them off right now, right? So that's the idea. Okay, so how do you have a successful SAT SBT? You have to make sure you're treating the PAD, which has been, again, shuffled into ABCDEF. So P is pain, which we just talked about, assessing pain. If the pain is controlled, they're going to do better with an SAT SBT, right? Because if someone's like agitated, moving all around, they're not going to pull great volumes, right? So make sure the pain is under control. So CPOT less than 3, numerical score less than 5, that's usually someone that's going to be successful on their SAT SBT. And hopefully we're doing that ahead of time. Hopefully we're not discovering that, the day of we're trying to wean. We want to try the whole time we're trying to get them to the point of extubation if we can. And then A is agitation, which you can kind of think of as delirium, but pain causes agitation, delirium causes agitation. So we got to fix the agitation. We got to figure out which one of these things is causing agitation. There's other things that can cause it too. Some medications have side effects of agitation, right? There's physiologic reasons why we might have agitation. But if we could control the pain and control the delirium, hopefully the agitation is going to come in suit. And how do we know someone's agitated? It's like they're trying to hit me. That's how I know, right? So that's, yeah, if they're agitated, that we score that on the RASS scale, right? So the RASS scale, on the positive end, plus 1, 2, 3, 4, 5. I think it goes to 4, doesn't it? So up to 4, that's 4 is violent and they're hitting me, right? Plus 4. Whereas plus 1 is they're just kind of squirming in bed. It's like, stop it. No, they keep moving. Stop it. No, they keep moving. Stop it. And they keep moving. It's like, let me give you some pain medication. See if this you stop it, right? So that's that's an agitation. And hopefully we can get that controlled. And our ideal control for every ICU patient is a RASS score of 0 to -1, right? So 0 to -1 is where you want every ICU patient's agitation level to be. And level of consciousness, that's how you assess level of consciousness. You want it to be 0 to -1. All right, so then what else? So then P, A, and then D for delirium. So we assess delirium because if they have it, we have to fix it. We have medications we can do. We have interventions we can do to fix someone's delirium. And how do you know someone has delirium? They're CAM ICU positive. So they're positive for confusion assessment method. That doesn't really make much sense in the ICU. So the CAM ICU is a scale or a procedure that we do every shift. Don't be an overachiever and do it every 4 hours. I see people doing CAM ICUs Q4 hours, and if you listen in, they're probably not doing Q4 hours. So it should be done, every shift. It should be done after sedation's off, but definitely every shift. You're doing CAM ICU, and if they're negative, that means they're negative for delirium. Great. That's what we want. That's going to be a successful wean process. That's going to help our weaning process along if they are negative for delirium. But if you go ahead and it's like, I'm going to take the sedation down, all right? And I'm going to do what? I'm going to do a cold turkey just right here. I'm going to take that sedation right off. But beforehand, they're already super agitated. That's not going to be a pretty situation, right? So we don't recognize they have delirium ahead of time. Okay? And of course, we can get pain medications to see if it works, because we always treat pain first. All right, so this is called the wake up and breathe, because it used to be 2 separate concepts. But I'm going to do an SAT, and then people forgot about the SBT. People did the SBT, and they forgot about the SAT. So it's called both. SAT and SBT, or the Wake Up and Breathe initiative. Came out like 2010 or so. And we do it how often? You do it every shift at 8 o'clock. So 08 and 2000, you're doing a SAT or SBT. If they're already off sedation, SAT's passed, right? But we do each one of these. How do you know they passed, or how do you know you can even do it? You're doing a safety screen for each one, right? They do overlap, which is nice, but they are different. So you do an SAT safety screen, and if they pass it, you do an SAT trial, or it's like saying HIV virus. It's a spontaneous awakening trial. You do, right? At 8 and 2000, you're doing this SAT, and you're seeing, hey, are they doing good or not? If they're not doing good, you're going to restart the sedation. Right? You restart the sedation at half the previous dose. So that way you can maybe, hopefully, stepwise wean them off the sedation. All right, so you have objective parameters. You say, oh, it's safe to take them off sedation, 100%. You're cold turkey, right? I get asked this, like people, one of you guys tomorrow is going to ask me, or you're not here tomorrow, are you? But you're going to ask me next week and say, hey, do I just take it off completely? Yes, 100%. It's off, right? It's down to 0, right? There are some medications where there might be little caveats here, but it's 100% off. All right, you're taking off all sedation as long as they met criteria. He said, well, Aaron told me, but then he's like, well, they're actively seizing. That's one of the criteria, the safety criteria you check before you take the sedation off. So again, this is RN driven. It's all, we know this process. You're gonna be competency to it. You're gonna be signed off that you know that this is how I take sedation off. And every shift, I should be doing this, right? So every shift, I should see my fentanyl, or my fentanyl and my propofol go from 50 and 2 to 0 and 0 at 8 o'clock, right? It should be completely off, all right? If they fail, they fail, right? We restart it at propofol at 25 and fentanyl at 1, right? We restarted half the previous dose if we need to. So we have objective criteria we look at. We see, do they pass or not? If they don't pass, we're going to try again in 12 hours, right? Does that mean you can't titrate your medications? No, you can still titrate your fentanyl from 2 to 1.5 to 1. Oop, they got pain. 1.5, no pain. 1.5, and then by 8 o'clock, it's already off. You're already done, right? So we still want to do that. Night shift is notorious for, let's let them sleep. Does propofol make you sleep? Did Michael Jackson sleep? No, I'm kidding. So yeah, I guess he's getting sleeping now, but there's no, does it cause a dreamless sleep where you're not getting REM sleep when you have propofol or Versed or fentanyl? It controls pain and agitation. It does not make you sleep, right? So what makes someone sleep is get them off sedation, right? So that's the key thing to think about, right? It's not, so I want to make them comfortable. It's like, yeah, maybe they're comfortable, but maybe it's too much sedation. It in of itself can cause more problems. All right, so we have objective criteria and safety criteria. We make sure that they meet, and then we take off the sedation cold turkey, right? We do sedation vacation, it's sometimes called. People like that because it rhymes. But sedation vacation or SAT are the same thing. You're taking them off sedation completely, 100%. You're doing a daily interruption of sedation. We're doing it every shift. We're taking it completely off, right? If they really have like a trauma patient, or they have like really bad like a lot of drains and tubes, we might keep the fentanyl. Maybe we're going to do like half dose, right? When I say I'm going to do fentanyl is at 2, I'm going to do fentanyl at 1 and take the sedation off. There are some little caveats there, but we definitely are going to do cold turkey if we need to. Okay, if you have like a COPD grandma and they're on like 2 mics of fentanyl, like, why are you on fentanyl now? It's like, well, grandma has chronic back pain and she's on these 5 pain medications. Okay, that makes sense, right? But if they don't have that, there's no reason to have all this medication infused in the patient, right? So that's the SAT. Who's in charge of the SAT? The RN, right? That's our job to make sure that the SAT gets done and they meet criteria. I'm going to do it, right? If they don't meet criteria, I'm going to document it in Cerner and say they don't meet criteria because they had this and this, or just this. And we'll talk about that in the next slide, I believe. All right, and then the SBT. So the SBT, the spontaneous breathing trial, we kind of touched base on that. We put them into a weaning mode, right? So we put, what's a weaning mode again? So pressure support is a weaning mode. So we change the mode of the ventilator. That's all they do. First of all, they do a screen, make sure it's safe. Because if it's not safe and they do it, you're going to against policy and against what you're taught. So you need to know that there's an SAT criteria and there's an SBT criteria. So as long as they check all those boxes, and Cerner kind of walks you through it, says, are they this, are they this, are they this, then do it, right? But if they meet one of those criteria for the safety screen, we're not going to be doing an SBT that day. But they are different enough. You can have someone that's not meet criteria for SBT, but they do make criteria for an SAT, all right? So we'll talk about that, some examples. So what else? So SBT, you're just switching the mode over, right? So usually a pressure support of 8/5, right? If you want to, or maybe even 12/5 to give a little more support, right? And then once they tolerate that, right, for a certain period of time, then we're going to decide, we're going to bring all this information to the provider and say, can we extubate them? And they will make a decision based on the clinical status. Say, oh no, the BUN's gone from 90 to 120 today. It's probably not a good day to take them off the ventilator, right? The renal function is getting worse, or their fluid overloads, right? Or their, their K is like 7.2, and I want to get that fixed first. I don't want them to get into a situation where they stop breathing, right? Now you have hypercapnia, hyperkalemia, and acidosis. That's a mixed acidosis. That's going to lead to a code situation. So they are still there to, be the end point, safety net, to make sure it's safe to come off the ventilator. And sometimes you can't find the MD and the patient just extubates himself. So that happens too. All right, so it's a wake up and breathe trial. That's the whole goal. You're waking up, you're sitting them up, you're making sure everything is optimized. Okay. Hold on, we're thinking here. There it goes. Okay, so sorry, I was really having trouble thinking. All right, so wake up and breathe.
Rise and shine.
What happens if you were in a situation like that where, for some reason or another, decided that even though they passed all that, to keep them intubated, do we just go back and restart everything and have those?
So yeah, so if your patient is like passing the SBT, you mean,
Mm-hmm.
they're doing great on the weaning trial, and they say keep them on the ventilator, there should be good reason, right? You can say, oh yeah, you can always probe them and say, hey, why do you want to do that? It's like, well, they've been intubated for 12 days. It's the first SBT. I don't feel comfortable right now, so let's try again at 4 o'clock to see if they do better. There could be that, but like, you're not going to restart sedation, right? So they've already passed the SAT. There's no reason to restart sedation. So we're on the SBT now. So we'll turn them back to volume control mode because we don't want them to to whimper out. It's like working out in the gym for 30 minutes to 2 hours versus working out all day to like 6 hours, 8 hours, or overnight, right? You do want their muscles to rest. Otherwise, you're not going to be able to pass it in the morning.
So you wouldn't keep it on pressure support?
You wouldn't keep them on pressure support, especially an acute patient. Chronic patients are a little bit different, right? When they're chronic trach patients, they've been vented for more than 10 days. There are some other strategies they can use, right? Because they are much more deconditioned than a regular patient. So they might do like a little more prolonged trials, or they might do like two to three trials per shift to see if they're doing good. So they have more confidence. But for the most part, for our first 7 to 10 days, what we're doing here is what we're doing. Right? If they don't want to extubate, put them back on volume control. Okay. So again, the SAT and SBT algorithm. So in yellow here, we got our SAT, right? We got safety screen and we have failure, right? So I did a safety screen. They met criteria. I've taken sedation off. How do I take it off? Turn it off, right? It's off. So you can just change it to 0 for now. Or you actually, the easiest thing using the IC, we're going to just put it to pause for 30 minutes, right? So we're going to see how they do with my sedation off for right now. As long as they met criteria, right? And this is RN driven, all right? So the RN is the one that's going to do this Q12 hours, right? And as long as they pass the safety screen, as long as I check these boxes, are they seizing? Nope. Are they in alcohol withdrawal? Well, this is a little asterisk there because we have medications that can fix that, right? Is there agitation? It's like, oh no, the RAS+1 can't do it today, right? So no, we can tolerate that. We have medications that can fix that. Which medication? Precedex or dexmedetomidine. That's the medication that can fix acute agitation, and it's also medication that can be given during an SBT and even once they're extubated. It's the only sedative, or it's not technically a sedative, it's the only medication we can give to control someone's agitation out IV infusion form after extubation, right? But no paralytics. Is that good? Right, so it's like, hey, taking sedation off, and hey, you're paralyzed too, right? So that's not great. So you want to make sure that if they're on paralytics, we're not taking sedation off, right? Paralytics come off first when you titrate paralytics, and then sedation comes off. And then no myocardial ischemia. How do you know someone has myocardial ischemia? They're clutching their chest and they're saying I have chest pain? Maybe, but they're vented and on sedation. How do you know they have myocardial ischemia?
Elevation.
Yeah, ST elevation, ST depression, what else?
Decreased cardiac output.
Maybe you might, you have your provider comes by and does a little bedside echo. He's, oh, look at that, you got wall motion abnormality. But more commonly, you're going to see like EKG findings. You're going to see ST depression, ST elevation, or T wave inversion, right? Those are usual signs of myocardial ischemia, right? And then normal ICP. So ICP less than what? Who knows ICPs?
Less than 20?
20, yeah. Normal ICP is like 12 to 20. All right, so less than 20 is fine, right? So if they're like ICPs in the mid-20s or 30s, definitely not time to take off sedation. Sedation will lower ICP. So not a neuro patient and they're not a cardiac patient, I'm probably okay to take them off sedation at 8 o'clock, right? And then what do? Every 12 hours, all I'm doing is completely taking it off, right? Perform SAT, that means we are off sedation. It's 100% off, right? There may be a little asterisk there for like a trauma patient or a patient that has a lot of pain, but it's, for the most part, it's 100% off. And then it's your job to assess what? Are they passing or not, right? Or pass, fail. So you're looking to see, do they have anxiety, agitation, or pain? Well, I got PR on morphine. I have medications that could fix that. I have Precedex. Does Precedex control pain? It does. So it's a pain medication and an anxiety medication, right? So it's one of those analgesic sedatives. It's one of those bee's knees. It's one of the holy grail of medications, right? So it's great in that it can do both of those, right? So we have medication that can fix this, right? Oftentimes they go, oh, they're failing the SAT, and they'll just say, okay, let's take off the propofol and do Precedex instead, right? And a rescue rate greater than 35, Precedex can help that, but if they're really breathing super fast and you are on Precedex, then it's probably time to restart sedation, right? And then O2 stats start dropping, so less than 88%. So their stats start dropping, that's someone that's failing the SAT, because what's the purpose of sedation? Yes, for ICP and for seizures sometimes, and for neuromuscular blockade, but it's also for ventilator synchrony, to make sure that they are synchronous with the vent. Because really, really sick patients, like ARDS patients, and really high PEEPs and FiO2s, and inverted IE ratios, those are uncomfortable. We want to make sure they are synchronized with the vent also, right? So if their stats are less than 88%, we're not going to be, they have failed. We're going to restart sedation how? At half the previous dose, if they fail, right? So if they fail, we're restarting, and then we're trying again at 8 o'clock on the next shift, right? So remember, you can always suggest dexmedetomidine or Precedex, right? As non-narcotic. It's not what's the word? It's not addictive, and it's not going to cause respiratory depression, right? They can still breathe when they're on this medication. It controls pain, and it controls anxiety and agitation, okay? Just another piece is vent settings. They play absolutely no role. So if a patient's on 60% PPO10, can I take them off the sedation? Yeah, I would probably titrate that down. But if they're like on 60% PPO8 or 60% PPO5 or even 70% PPO5, I could still just take it off completely, right? I would probably say, well, my stats are 97%, I got a lot of wiggle room. But my stats are like 89% already, I'm probably not going to take it off cold turkey. I'm going to titrate it down, right? Because what is a failure criteria is the saturation. The screen criteria, yes, don't have vent settings, but the failure criteria do. The vent settings are really, really high. You're probably going to fail anyways. We can see the writing on the wall already. Okay, so SB2 and rescue rate are factors. We just got to consider that, before we take off the sedation. But sometimes you have patients on ventilators and they're requiring a lot of support. It's like, I'm not going to take it off. I'm not going to take it off. And then come to find out, you take it off. Someone does do what they should be doing. They take it off, and there's actually no neuro exam underneath because they had too much sedation for 3 days. It's like, oh, let's go to CT. Oh, they had a stroke 3 days ago. So that's one of the reasons why we want to take sedation off also. Right? At any point, a patient can fail when you take them off this. They can fail within 30 seconds, or they can fail within 30 minutes, right? So how long should they be on an SAT? 30 minutes, that's it, right? So 30 minutes, they've 100% passed, right? 20 minutes, yeah, you're doing great, you can walk them through it. Who else can walk them through it? Family, right? So you can always bring the family in there. Hey, I'm going to take them off the sedation right now. They may get agitated. You can hold their hand. You can make sure let them know you're here, as long as they like you still, right? There's like, what's this person doing here, right? So anyways, you can use the family there to help them through this process, or you can grab a CNA to help, say, hey, I'm weaning this patient. Yesterday I got reported, they said they had a crazy time. They were wild. They're hitting the nurses. They spat on 3 nurses. They called it code gray 7 times. Every day, every shift is a new shift, right? So even though you had the worst horror story ever before, you're going to try every single shift, right? That's the point, is to get them off the sedation, because sometimes they probably increase the sedation after that event, and we want to then back off because their disease process might have been resolving after 12 hours or after 24 hours. Okay, so do you need a MD? Do you need to tell them, hey, my patient passed the SAT, can we do an SBT now? Do you need them involved? No, this is RN and RT driven. All you're doing is make a call to the RN or the RT, and you're saying, hey, they passed the SAT, can you put them on a weaning mode? And what are they going to do? They're going to say, did they meet criteria for weaning, right? So RTs know this, and we know it. We know, so you don't want to make a dumb phone call. Oh yeah, PEEP's 12, can't do it, right? So that's someone who does not meet the safety screen, right? PEEP less than, our protocol is 5. So if PEEP is 5 or less, you can go ahead and throw them on a weaning mode. But if PEEP is 8, 10, they're not ready for weaning. But sometimes you're like, this patient's perfect, why can't they wean them? Then that's where you would then involve the provider and tell them, hey, they're doing great. The only thing that's making us not do it is because their PEEP is 10. It's like, oh yeah, look at their morbid obesity, 600 pounds. Yeah, they probably need PEEP of 10. That might be something that they might need, and let's go ahead and try it anyways, right? So event settings do play a role in SBT. There is overlap with the SAT, right? So if they are, agitation, we can control that with Precedex. If they're, they don't have myocardial ischemia, right? If you're not going to do a breathing, I know you are requiring oxygen right now for your heart, but let's make you work harder because you might breathe faster, you might get increased shortness of breath when we put you on this breathing trial, right? So yeah, no myocardial ischemia, obviously. Hopefully they're not paralyzed by this point. Hopefully you recognize that up here, right? So you're going to make sure they meet this criteria before they go ahead and put them to a weaning mode from a volume control mode, for instance, right? So no vasopressor use, that's kind of with a grain of salt because, low vasopressors is fine. Levophed at 4 mics, phenylephrine at 0.4 mics, that's fine. They're coming they're going down in vasopressors. That's perfectly fine. But what is here is FiO2 and PEEP. That's our settings we got to eyeball to make sure that it's okay to come off. Okay, so the SBT algorithm, again, there's a safety screen and a failure criteria, right? So you put them on the SBT trial or the spontaneous breathing trial, and you see, are they passing? How do you know they're passing? Well, just like before, are their SATs dropping? Is their respiratory rate going up? Are they getting distressed, right? The work of breathing is really fast, right? They start developing AFib RVR, right? They start going to VTAC. They start having all these runs of VTAC, right? They start getting like an acute mental status change. They start getting a stroke in front of your eyes. They failed, right? So let's go ahead and put them back to their previous mode of ventilation, right? So we're looking at this for how long? 30 minutes, that's it. So 30 minutes is it. So if you have someone that tells you, oh, let's wait 2 hours, or let's keep it on until 4 o'clock. That's way too long for an acute intubation. If it's been less than 7 days, 30 minutes is it, right? If they pass it for 30 minutes, we got to decide, are we going to extubate or not? Okay. If they fail at 30 seconds again or 30 minutes, then it's time to put them back in the previous mode. Do we restart sedation? No, we're beyond that. We passed that, right? We're done with sedation. Now we're in the SBT mode now, right? And can we start Precedex? Yeah, you can start Precedex. It's like, well, that's a little technically sedation, right? Yeah, but it's going to be not going to depress the respiratory drive. It's going to keep them awake, alert, and calm, or a RASS score of what? 0 to -1. That's where we want them to be, okay? So yeah, if they have precluding vent settings, we can discuss it with the MD and let them know, hey, we're PEEP of 6. Can we take it 5, or can we try it with a PEEP of 6? Can we try the breathing trial with that? And again, agitation can be controlled with PRNs and Precedex. We have medications we can give for delirium. Okay, so what's Precedex? What's the generic name? Dex what?
3 of the hardest things a healthcare worker can say.
I love this guy.
I was wrong. I need help. And dexmedetomidine.